Hey guys, are any of you throwers dealing with hip pain? We're going to show you some videos about what you can do to protect your hip. Ed Martell here from the OAI. Recently I had a rash of hip impingement pain for throwing athletes, which is relatively rare. I've been doing this for 17 years and it's not something that I've seen more than once in 1 month. But I had a couple athletes show up and you guys were introduced to Max Bordell, who actually had a hip surgery as a result of an internal impingement. They had to go in and debride and remove an osteophyte. But I've had a couple athletes with snapping hip syndrome, but we thought it was important to talk about it because you can end up with some hip pain if you're actually not you're not loading the right way, or you don't have mobility internally so that your hip joint can articulate correctly. So we're going to show you some videos of things that we did with those athletes, as well as some stretches that you can use in combination with some upper extremity scapular stability stuff, exercises in combination that we use all the time with OAI athletes that can potentially help you from developing hip impingement at the same time improve your mobility and your stability. Ed and Max here from the OAI. What we're going to do is we're going to show you some of the hip mobilizations that we actually used with Max, but we also use with people who have tightness in their hip or stiffness in their full end range flexion so that they can go into abduction and extension. So Max is going to use the belt. We'll attach it to something very, very secure because you got to put a lot of force through it to actually mobilize the hip joint. It's a very stable joint. So he'll go right into that hip abduction, and then what he'll do is he'll lean into it and do a posterior mobilization. You want to get that way up into the proximal joint. So he'll lean into it and he tries to inch his leg further and further, and he goes into abduction, and then he sometimes drives into internal rotation and goes into external rotation. So he'll do repeated activation into that range. We'll sometimes use safety belts because this can sometimes be less resistance than what's required when you get in a larger individual. So we'll do that direction. We'll have them go the opposite direction. So we'll do kind of an anterior medial mobilization. Sometimes you're dealing with a capsular impingement. Most times at that age, that's usually what it is. Max was odd because he had osteophyte formation, but when the doctor went in there, he said that stuff had been in there for a while. So we'll go into varying degrees of flexion, hip internal rotation, extension, but the key is trying to get your leg as far back and abducted as you can. So without the use of a manual intervention, which is what we also did in therapy, which is belting and doing forceful mobilizations through the hip joint, on your own you can mobilize your own hip just by attaching a secure band to something that doesn't give, and then you take yourself into that internal rotation right to the range where you feel that impingement. And sometimes it's as simple as finding what directional mode provides you with relief. So you're doing a mobilization multi-directionally, but your goal is to try and find a mobilization that will allow you to alleviate some of that pressure. It also can tell us as clinicians what's provoking it, but in the end it's just one thing that we did. You can use it as part of your own mobility program. Another self-mobilization that we use is a full rock back with kind of a forced internal rotation. A lot of times a rock back can tell you what will happen in the acetabulum just by what leg rotates which direction. So when Max would first do it, he would rotate into flexion and external rotation, so his one foot would go towards the center. So what we would do is we would force him to keep his hip relatively internally rotated while he would do a rock back. So Max is going to show you, we're going to show you what he would do sideways so you can do it. So go ahead and let your feet hang off the edge there in the direction. And so you'd pre-position the bolster in between his malleoli or his tibia, and then from there he would initiate with flat lumbar spine, activate his core, push himself towards the back, and then slowly drop his lumbar spine as he would work into hip flexion. So he would actively pull himself with his hips into that range, and then we would sometimes offset it where we'd force him to go into either hip abduction or adduction, so we'd have him laterally sway his pelvis. But the whole goal is to try and improve his hip mobility as he goes further into flexion, so when he would throw, he wouldn't be pinching his hip up against the same tissue or the same structures that were causing the impingement pain. So you got to think three-dimensionally. So he would hold the contraction, and then from there he would immediately go into an activation, which is what we're going to show you next. So turn to the side so they can see where you put the bolster, so you're going to be facing that direction. So from this position right here, you can see you put it right between the ankles, and then he would rock back, make sure the lumbar spine's flat, try and keep himself centered. Max would actually deviate off to the side, and his hip would externally rotate, which is a clinical indicator of something going on in the acetabulum that's not symmetrical. So then he would work himself into different positions and then do the same mobilization, and we would even increase the amount of internal rotation on the impingement hip. And even prior to his surgery, this would provide him with alleviation, which would allow him to throw. So we would do lateral traction with the belt. We do mobilizations multi-directionally, which we showed you in the previous video, and then we'd have him do things on his own to try and improve the joint's mobility. So you want to have as much freedom of movement as you can, as far into the range as you can, so your muscles can activate and create speed and force without causing any type of deceleration or impingement or asymmetrical movement pattern. So we're going to show the activation into the range next. So you may have seen some of our previous serratus videos, but when you're dealing with a hip mobility issue, sometimes you can combine a serratus activation, which can assist the thrower to improve his scapular upward rotation. But in this position, we'll put him on a bolster or a pad. We'll have him maximally internally rotate his hips. Then from here, using an SFMA band, make sure it's secure down and low. And then what he does is he pushes his way back into hip flexion. And that hip internal rotation, sometimes you have to have a little bit of pressure. So as a therapist, I'll be here pushing, and then I'll have him activate into that range. So you always want to try and reinforce your mobilization, multi-directional mobilizations with activations into the range, so you improve the joint's mobility. So it's not enough to just passively do it. You have to activate into that range and challenge them to contract the tissues further into the range than they previously had to give them that usable length. I know you've heard me say it, correct and create in usable length. If you have mobility and you can't use it, it doesn't matter. So that's the whole point of our corrective exercise program that goes along with the phase-specific throwing program, is to improve your body's ability to acquire the positions of the throwing motion so that you can use those new ranges to create force and avoid injury. So that's it for today.
Make sure to subscribe, hit this little button over here. Also, like our video if you like what you saw there, and hit the little bell so it gives you notifications you don't miss any videos in the future. All right, thanks guys.